Hey class, welcome to this lecture on FDG imaging of the brain. And this lecture focuses on the non-oncologic applications of FDG imaging. So just a brief overview of brain imaging. We do have FDG, PET, and PET-CT. You can also do PET MRI, which is really, really good for the brain. You see in the image of the MRI right there, the brain has a lot of detail. The high amount of detail that you get with the brain with MRI makes it really, really good to overlap with the PET data. So PET MRI, that's one of the advantages, is that it's really good for neurologic imaging. PET-CT is okay though. We don't have a lot of PET MRI scanners out there. Not everybody has access to them, so PET-CT is the most common thing that you will see. Remember, we also have amyloid and tau imaging as well as F-DOPA. And then when we talk about neurologic imaging, we will specifically talk about gliomas, which are primary brain tumors, because they are a little bit different. So this is breaking down the neurologic imaging in PET. Today we will talk about the non-oncologic FDG applications, and that includes stroke, ictal studies, which is epilepsy, and there are some psychiatric or mental disorders and even neurodevelopmental disorders that can be imaged. FDG just looks at glucose metabolism in the brain, and so anything that may affect glucose metabolism, whether it's problems with perfusion, hyper, or hypometabolism, that will show up with FDG. With dementia imaging, we have amyloid, tau, and FDG. We will not talk about that today. Parkinsonian syndromes and Parkinson's disease can be imaged with F-DOPA. And then for oncology, you have FDG, that's FDA approved. It's not really great for the brain. We'll talk about that when we get there. And then we have PET for gliomas. So this is what brain scans look like with FDG. One thing that I want to say before we start talking about FDG is that it is extremely important to get a good detailed history with FDG studies. It is also vitally important that the patients are prepped properly. If patients are looking at bright lights, listening to music, watching TV, playing on their phone, that affects the glucose metabolism in the brain. Anytime you are using your brain for a specific task, your brain will naturally send more blood flow to the area. That area will become hyperperfused, and it will also become hypermetabolic, which means it will start utilizing more glucose because those cells are functioning more than the rest of the cells in the brain. And so patients have to be placed in a quiet, dimly lit room. It's very important to follow that prep before they're injected and during the uptake phase. And it's also extremely important to get a really good detailed history because a lot of things can impact brain metabolism. And so this is a picture on your screen of somebody who is cognitively normal, who had an FDG study on the left, and then on the right, somebody with Alzheimer's disease, and you can see the arrows are pointing to the areas that are atrophied and are having hypometabolism of glucose, which means the glucose metabolism is decreased. FDG is the most widely available PET tracer for pretty much everything we do for PET. It's widely used for oncology, cardiac, infection, and neurologic imaging. For a really long time, it was the only FDA-approved radionuclide that could be used for brain imaging with PET. It localizes in areas of increased glucose metabolism seen in high physiologic activity. In the brain, glucose is the predominant substrate for metabolism. Intense tracer uptake is seen in the normal cortex and the basal ganglia. We will see gray matter more than white matter. The malignant brain tumors will show increased glucose metabolism, but primary tumors do not. And FDG neurooncology can be really tough to distinguish from inflammation or tumor. This is where it gets very tricky for doctors to interpret any of the images, because no matter what you're doing the test for, you have to get a really, really good history because a lot of things will impact it. Even certain over-the-counter prescription or illegal drugs will impact the glucose metabolism of the brain. Even dietary issues, nutritional deficiencies, things like that. And FDG uptake can be seen on PET-CT and FDG PET imaging. So the rationale for the test is that it is a diagnostic tool to evaluate the brain's glucose metabolism and function. Since a lot of things do that, we can image a lot of things with FDG. The brain will always show up really, really hot on FDG studies because your brain actually uses about 20% of the glucose that's available. The FDG test will accurately assess changes in metabolic activity, and it may explain irregularities in mental or physical status. Of course, not just different diseases, but also neurologic and mental health conditions can alter that glucose metabolism or the metabolic activity of the brain. Some other benefits, looking at epileptic seizures, grading tumors, directing biopsies, evaluating malignancy, and something that is seen on other imaging, differentiating between radiation necrosis and tumor, and differentiating toxoplasmosis from CNS lymphoma. Talk about the cancer stuff a little later on. Also, though, it's really good for looking at infections in the brain and looking at how that's changing the glucose metabolism. And then at the very end of this lecture, we will talk about how FDG brain scans are being used in criminal cases as well. The radiopharmaceutical is FDG, that stands for fluorodeoxyglucose. And this is involved in glucose metabolism, so it just follows that normal pathway of glucose metabolism until it gets into the cell. So glycolysis is a set of reactions that converts the glucose into pyruvate or lactate within the cell. That's the process that FDG normally follows. But as you can see in the image, there's one step that's missing. So the process of being taken up by the cell on those glucose transporters and being placed into the cell is normal. That happens with both glucose and FDG. But the second step is that another enzyme has to turn that glucose into fructose in order for the cell to actually use it. That doesn't happen with FDG. That enzyme does not convert that, and so it doesn't participate in cellular metabolism. So that means a couple of things. First of all, the FDG gets transported into the cell just like sugar, but then it gets trapped there. It never goes any further, it never metabolizes. So that means when the FDG goes into the patient's cells, it's going to stay there for a while and allow us to image it. So it's actually what we want because it's mimicking glucose metabolism, but it's missing that last final step. And so it gets trapped in the cell and we can image with it. Now, the other important thing to remember is that step right there where it doesn't ever get metabolized by the cell. That means that it doesn't actually ever raise a person's blood sugar. And this is something that you will want to keep in mind because patients, especially diabetic patients, will ask you that because you tell them you're giving them a radioactive glucose or they hear the name glucose in it and they worry that it's going to spike their blood sugar. And you can explain to your patients that it doesn't do that because it doesn't get metabolized by the cell. That last step is missing. And so it doesn't actually impact the patient's glucose levels at all. There are a lot of indications for doing FDG brain imaging. If somebody has behavioral changes like depression, difficulty with speech or swallowing, involuntary muscle activity, general confusion, any kind of cognitive decline, or mild or severe cognitive impairment, especially if there was a sudden onset. And then if they have a seizure disorder and they want to locate the location of the seizures, those are all kind of behavioral indications for doing an FDG brain study. They can also be done to rule out certain diseases, help get a differential diagnosis on things like dementia, evaluate tumors to see if they're primary or metastatic and where they're located, how metabolically active they are, and then also assessing things like traumatic brain injury. There are a couple contraindications for doing FDG brain scans. Of course, pregnancy and breastfeeding are not absolute contraindications, they are relative ones. And so that means if they can still be done on someone who is pregnant or breastfeeding if there is a medical necessity and if the benefits outweigh the risk. Patient must be properly informed and sign a waiver. And then, of course, always follow the imaging facility's radiation safety guidelines and make sure that the patient is educated, signs a release, and that they have been given proper written instructions and that they actually understand them and agree to follow them. Now, if somebody's glucose is really high, you can't do the test. This blood glucose level is going to vary a little bit per facility. And typically, if it's greater than 200, you will want to reschedule the scan. For brain scans, there's a little bit lower threshold than oncologic studies. So for most brain scans, if it's between 150 and 200, their doctor might want to consider rescheduling it or trying to bring their glucose down a little bit. And if it's higher than 200, they will reschedule the scan. The reason for that is because if you have a high blood sugar, then the cells in your body are already saturated with sugar. They have an overabundance in your bloodstream. They're not going to take up any more glucose because they're fat and happy on everything that's already in your bloodstream. Well, what's in your bloodstream is not radioactive, so we can't see it. So when you give somebody the FDG and their blood sugar is really high, it'll kind of circulate, it'll get forced into their soft tissue, which is the last place glucose goes, and it just won't uptake. So that's something that is really important to consider. You always want to make sure you check their glucose before you start, because otherwise it just won't go to you actually won't see your brain very well. Patients' inability to lie still for 30 to 60 minutes has to be taken into consideration. You can give sedation if needed. Of course, follow your department protocols and policies. You as the tech may not be able to some places, but that just is going to allow the patient to relax a little bit. You would want to give it about 20 minutes or so before you start imaging them so that it has time to kick in. This is really not a common practice. Most of the time, patients are going to be able to just lay down and lay still, or you can work with them with guides and things like that to help remind them to hold still. And so it would be very, very rare occasion that you would need to sedate a patient for this test. The ICRP, which is also known as the International Commission on Radiologic Protection, does not recommend interruption of breastfeeding after FDG administration since little FDG excreted in the milk. So what that means is the international body that makes recommendations for all things radiation, they actually don't recommend interrupting breastfeeding after FDG because they said not enough of it goes to the milk. However, lactating breast does accumulate FDG, and so the problem with that is if the mom is holding the baby and the baby's eating, then that baby is really close to the radiation exposure because that mother is extremely radioactive. So it's suggested that the actual contact between the mother and the child be limited for about 12 hours after injection, just to reduce the radiation exposure to the infant from the mother holding them. So the baby can be given bottles by a different caregiver. It's just that that mom should not hold the baby and feed the baby for 12 hours. So that it's recommended that the infant be breastfed just before injection to maximize or minimize, I should say, the time between the injection and the next feeding. But breast milk may be expressed and fed via bottle, like I said. It's just that that mom should not be the one that's holding that baby for at least 12 hours. And nothing terrible will happen to the baby if the mom breaks that rule. That's mostly because babies are more radiosensitive and their cells are still developing. And so we want to follow ALARA practices and keep the baby's exposure to as low as reasonably achievable. So that's really important that the patient or caregiver be educated and given written instructions. There's a diet that needs to be followed, plus the blood sugar, plus the prep of a quiet dim lit room. So there's a lot of moving parts to an FDG study that really have to be followed because if they're not, it will impact the glucose metabolism. Patients should be NPO for at least 4 to 6 hours. They can have water, but nothing else. And then you want to hold any fluids containing dextrose or feeding if they are an inpatient for 4 to 6 hours. They need to be fasting during that time. And then right before injection, you want to check their blood sugar. If it's over 200, you will need to reschedule. And then they also need to discontinue anything that could affect their glucose metabolism for at least 24 hours prior to the test. So that includes caffeine, alcohol, any other drugs. Some things are over the counter, some prescription or legal medications. And then just avoid anything that's going to impact their glucose uptake. When you're obtaining a medical history for somebody with an FDG study, you want to get a very accurate, detailed list of all their medications, any recent surgeries that they may have had, and a really good history, whether or not they have diabetes, if they've ever had any head trauma, memory impairment, stroke. Transient ischemic attacks are also kind of known as a mini stroke. So a lot of older people would call it that. And then epilepsy, if they've ever had seizures or seizure disorder, they've ever had any vitamin or metabolic deficiencies, and anything that would affect their brain at all or cause trauma, bruising, bleeding, anything like that within the brain. And then results of any neurologic, psychiatric, or mental status test, because patients who have certain psychiatric disorders or their mental status is compromised, like they have like depression or something like that, even anxiety, that can show up on the FDG test as well. And then if they've had any other brain imaging studies, it's always important to ask that CT, MRI, or SPECT. And then PET is on that list also because some patients do get multiple PET scans. For example, patients with dementia might get amyloid, tau, and FDG before or during their treatment. And patients with brain tumors might get multiple different types of studies as well. FDG is administered via IV. The adult dose is about 10 millicuries. The typical range is 10 to 20. You will see that fluctuate a little bit too. It's very common if your range is 10 to 20, patients or technologists will order a dose that's like 16 millicuries or 15 millicuries because FDG decays quickly, and that extra little bit that you ordered for the time, it'll still fall within your range, but it falls on the higher side of your range. And that gives you the leeway if your patient is a little bit late, if you get behind in your schedule, or if you have trouble getting the patient's IV, all that stuff, ordering a little bit higher will help that. You will also see a wider range in places that have digital PET because their cameras are so sensitive and so efficient that they can actually give a lower dose and still get good counts. So don't get hung up on that dose. That's just the typical range that you'll see is about 10 to 20. Of course, there's a formula for calculating the children's dose, and it's pretty small compared to the adult dose because children are more radiosensitive, but it's 0.14 to 0.2 millicuries per body kilogram. Sedation, like I said, can be used if necessary. It's really rare, and you want to give it kind of close to the imaging time, depending on what you're doing. If they're just taking like a Xanax or something, once you would want to do that, like have them take it about a half hour, 20 minutes before your imaging. But if you're actually sedating them with IV medication, then you want to do that pretty close to right when you're putting them on the camera. And then if you do end up having to use sedation, they have to have a driver. For the acquisition, you want to confirm that the patient followed their prep and other instructions, obtain IV access, and monitor the flow. In a dimly lit room, you will have the patient sit or recline for about 20 to 30 minutes before you inject them. Now, it's best practice to put them in the dimly lit room and start their IV. You want to start it where you can see. So whether you start the IV and then put them in the room or put them in the room and then close, turn the lights off, doesn't really matter. But you want to start their IV first because that gives them time to quiet down and relax for that 30 minutes before you inject them. If people are stressed out about their IV or you have the lights on, you're talking to them, they're experiencing pain, that can all affect their glucose metabolism. So get the IV out of the way and the finger stick for their glucose, and then put them in a quiet, dimly lit room. They can sit or recline for about 20 to 30 minutes. And then you want to explain the test really well to them before you put them in that room and let them have that resting time because when you come back to inject them, you don't really want to talk to them. They're not allowed to really talk that much or read because that can affect the areas of the brain that get glucose. You want them to remain quiet. Always inform the physician if the patient was unable to lay still or didn't follow that prep during the pre and post-injection uptake. Patient will void prior to imaging and then put them on the table with their arms down to their side. You can use a head holder if you want. It is best practice because it will kind of hold their head in place so they can't move. You don't really want to use a foam headrest, and there are specific head holders that come with camera manufacturers, and you can use those. You can also lightly put like a Velcro strap or something around the patient's head, very loosely, but just kind of to remind them to hold still for the images. And you want to monitor the patient for movement and things like that during the scan, but you don't really want to interact with them a whole lot during their uptake phase. So injection to scan time is also going to vary slightly by facility protocol, but it's going to be about 30 to 60 minutes. You need that to get taken up by the brain. It'll get taken up by the brain fairly quickly because your brain metabolizes glucose. And like I said earlier, it uses 20% of what's available to your body. And so your brain's using a lot of it. It's going to get taken up by there. Peak kind of uptake time is around 60 minutes for FDG. That's when you'll see the best uptake in all the tissues of the body. That's the minimal background, so you get the best target to non-target ratio or signal ratio, but then you also don't have a lot of washout yet into the urinary system. So that's your sweet spot is 60 minutes. Energy peak is always a wide energy peak with PET, but you'll have it to be at about 250 to 600 keV. You can scan them in 2D or 3D. Remember, when you're doing 3D, it's a lot more sensitive. You get a lot higher count rate. When you're doing 2D, it's going to take a lot longer because you don't have as many counts. You can typically scan them in one bed position for the brain. If you're doing 2D, it's going to take 20 minutes. If you're doing 3D, it's going to take 6. And make sure that you have the entire brain in the field of view. You want to include the cerebellum as much as you can. And then afterwards, you'll do attenuation correction. If it's standalone PET, you can do that with cesium or germanium source. But if you are doing PET CT, which is the most common, then you would use the CT acquisition. And this is just a kind of visual aid to show you the process. So patient will come and rest for 20 to 30 minutes in that dimly lit room in the quiet. Patient cannot read, watch TV. They cannot have their phone on during that time. They've got to just sit there. You want them to try to stay awake, but you also want them to just kind of sit there and relax, because if patients fall asleep and they dream, that can also impact their metabolism of the glucose when you go to inject them. Inject the patient with about 10 to 20 millicuries of FDG, and then let them sit for another 30 minutes to 60 minutes in that same quiet, dimly lit room. Still not allowed to do anything. We don't want them falling asleep. No noise, no TV, no reading, no talking, no playing on their phone. At this point, when they're in the uptake room and you need them to be quiet, they should not have any family members with them either, because the family members always end up talking to each other. And then sedation if necessary, 20 minutes for 2D scanning and 6 minutes for 3D. When you process the images, you'll have transaxial slice thickness of about 2 to 4 millimeters. You'll use filtered back projection. Remember, all PET initially uses filtered back projection. That's how it creates the lines of response. But then when you actually reconstruct the images and fuse them with CT, you use iterative reconstruction because the CT provides that patient map for us. And then there's always manufacturer recommendations for how many iterations to do, the final smoothness, things like that comes from the manufacturer's recommendations. The brain will be displayed in transverse coronal and sagittal planes, and then processing techniques will vary slightly by equipment as well. So this is a normal study. You will see that there is regional cerebral metabolism. You'll see that there is a lot of gray matter, not a lot of white matter, and you want to look for symmetry. So this is just kind of showing you that their normal aging will have some cortical atrophy, and that's normal as patients age. So as you're doing patients that are older for any FDG studies, just know that they may, have some atrophy that shows up, and that's normal. So with FDG, like I said, you want to look for symmetry. You'll have more uptake in the cortical region or the gray matter that outlines the brain. Mildly decreased mid-temporal lobe activity. That is normal as well. I'm kind of pointing my laser pointer at it. You see it right there. And it should still be fairly symmetrical. It's really important that you have their head straight when you're looking for symmetry. Otherwise, you're looking at two different areas of the brain and trying to make them symmetric. And so it's very important for some symmetry that the patient is positioned properly. And then it's also normal to see some hot spots in the posterior cingulate cortex. You will also see more gray than white, especially in the frontal parietal occipital lobes and the basal ganglia. Basal ganglia is right here, kind of in the middle. You see the striata there. And then it's normal for the cerebellum to be a little bit lower activity because you have more white matter. This is an example of an abnormal study. This one is actually Huntington's disease. We can also image Huntington's with F-DOPA, so we will talk about that in a future lecture. But this is showing hypometabolism. Huntington's disease is a neurodegenerative disease. It's progressive disease with no cure. And so the arrows there are pointing to areas that are hypometabolized or have decreased uptake. One of the things that we can do with FDG is image for stroke. This is not really well accepted. There's a lot of downfalls and kind of pitfalls of it, but it is something that can be done. Still, SPECT is the standard for that. CT and MRI are best for stroke imaging. That's why you have stroke protocols for CT centers and things like that. But FDG can be used later to look at how the stroke is affecting their glucose metabolism and seeing if perfusion has been restored. And it is important to note that there are two different kinds of stroke. Ischemic strokes and hemorrhagic strokes. Ischemic strokes are there because there's a lack of blood flow. The tissue's kind of starving for oxygen, nutrients, and blood flow. And eventually those cells will just die. That's an ischemic stroke. Now, that could be caused from arteriosclerosis. There could be a blood clot or an occlusion in the blood vessels. There could be something more acute and emergent, like an embolism that forms and travels to the brain. And then there's hemorrhagic stroke, which is bleeding. This is where there's actually a breakage in the blood vessels and blood starts spilling into the brain. This could happen for a number of reasons. It can happen for trauma, chronically high blood pressure, any kind of malformation of the blood vessels, cerebral aneurysm will do it. And like I said, any kind of head trauma or anything that leads to a bleed. You can see the progression of each disease listed here. Both of them will go through their own process, but eventually the cells will die. There'll be lactic acidosis that occurs. The cells will rupture and their cytoplasmic contents will spill into the extracellular space. And this will lead to inflammation and eventually necrosis and tissue death. So different causes, different things that lead to it, but they will all eventually lead to edema. Inflammation is yellow on here. If it wasn't already highlighted, I would highlight it to point it out for you. FDG is going to go to inflammation, and there is inflammation that occurs after a stroke. That makes it really hard to actually image the stroke and get accurate results. And so that's one of the major pitfalls. So FDG can be used to assess the pathophysiology of a stroke, and it's used in many contexts. It's not good for an acute stroke, but it can be used for it. It's more often used at looking at regional blood flow, seeing if perfusion has been restored, and seeing any changes in metabolic activity. And if there's any areas of ischemia or necrosis or death, that will show up. But PET's ability to measure inflammation allows for really good measurement of arteriosclerosis, plaque vulnerability, things like that within the blood vessels of the brain. And it's also widely been used to look at ischemic insult, which is like the effects of ischemia. But post-stroke recovery is a very complex process. Your brain naturally has inflammation there, and that inflammation is part of your immune system to help your body heal. But you have scar tissue forming, you have fibrogens going there, fibroblasts, all those immune cells and cells that help to recover and create scar tissue. All those cells are rushing to the area. You have inflammation, and then you also have the possibility of further bleeds, and then you also have some cell death that's occurring. And so all around normal metabolism. And so it's very complex, and there's a lot of things that can alter the FDG uptake in that process. And so that's where good history and things like that come into play, knowing what kind of stroke the person had, where, the extent of it, when it happened, all of that stuff is important. So, like I said, there's pitfalls. One of them is a lack of standardized protocol, knowing exactly when in the stroke process the FDG is best and how to image them. Another is the long uptake time for FDG. It's not good for an acute stroke. And I mean, think about it. They have CTs with stroke protocols that the patient can be done in 5 to 10 minutes. But with FDG, the patient who's suspected as having an acute stroke would have to sit for 30 minutes in a quiet, dimly lit room, then be injected, then sit for another 60, and then be scanned for 20 if you're doing 2D imaging. That's over 2 hours that patient with a suspected acute stroke has been getting their FDG scan. It's really just not practical, especially when you could do an MRI much quicker, or you could do a CT in about 5 to 10 minutes. So that's something that has always held FDG back with stroke imaging. There's also transient glucose metabolism changes after stroke. There's transient hyperglycemia, which means that an area will just be hyperperfused and then it won't for a while. That makes it really hard. You got to image them at the right time, and you don't know when the right time is. You're just guessing. So you might catch it, you might not. And then there's peri-infarct spreading of neuroinflammation. Peri-infarct just means around the infarction, around where those cells died. and those can produce false results as well. So a big pitfall for FDG is that the area of the stroke will have decreased perfusion and metabolism, but then there are also transient hyperglycemia where it might take up more all of a sudden. And then also localized inflammation will increase uptake in that area. So all of those things kind of work together to make it really difficult to get a good, accurate diagnosis with FDG for strokes. You will talk about SPECT imaging with technetium agents, and those end up being a lot better for stroke imaging. And now we have epilepsy imaging. This is another one that can also be done with SPECT, but it has been replaced with PET where PET is available, just because you get a little bit better imaging quality with the PET. And one of the problems, though, is still the PrEP, the quiet, dimly lit room, all of that stuff. So the image that you're looking at is an interictal and ictal PET. Ictal means at the time of their seizure, and interictal means the resting phase, kind of when they're between seizures. So interictal means they're just kind of normal hanging out, but ictal means they're actively having a seizure. What you see in these images is that at their baseline, when they're not having a seizure, there is an area of the brain that is hypoperfused, which means or not really hypoperfused, but hypometabolic, which means it's not really metabolizing glucose. It's a low uptake in that area. But then during the seizure, that area becomes very hypermetabolic and is using up a lot more glucose than the rest of the brain. So that's something that's pretty common with seizure disorders. That'll be hypometabolic at rest, but during the actual seizure, it will be hypermetabolic. So it will show up as hot. Ictal imaging or epileptic imaging is often done as a pre-surgical evaluation, and this looks at the pharmacoresistant epilepsy, so it's people who drugs aren't working for them, they're still having seizures, and it's done to identify the area of the brain that the seizure is coming from so that doctors can operate on that specific area of the brain. It has much higher sensitivity than SPECT, especially in the temporal lobe. It goes up to about 80-something% of seizure foci that it will find. And SPECT is only in the 60s. So it's much more sensitive to actually finding the disease. It's not as great for extra temporal lobe epilepsy, which is epileptic seizures that happen outside of the temporal lobe. It just the sensitivity and specificity goes way down for that. It is best paired with MRI or PET-MR if you can, or correlating it later with the MRI studies. And remember, ictal phase means it's during the seizure, and interictal phase means it's during rest. So here's the protocol. For part 1, it's a baseline interictal study. Patient is injected at rest interictally following normal FDG protocol for the PrEP in the quiet, dimly lit room. So the protocol is exactly the same, 30 minutes, inject them, wait 30 to 60, then scan them. So that basic protocol that I told you at the beginning is the same protocol pretty much for all of them. The difference with epilepsy is that the patient is getting scanned twice. They will not be scanned twice on the same day. They will be usually a few days apart, but they will be brought in and scanned in their hospital usually, and it's just the baseline. And then in their hospital room, typically is where this occurs, but they will induce a seizure. So if the patient gets a seizure when they're playing a specific video game, then they will have that patient play that specific video game until they seize. If it is, strobe or flashing lights that cause the seizure, then they will have that environment where there is flashing lights until the patient seizes. The goal there is to have the patient seize in a controlled environment. They're always surrounded by nurses and healthcare providers to make sure they don't hurt themselves. It is controlled, meaning that area around them is set to where they can't hurt themselves or to minimize the risk of them hurting themselves. And they do have an IV line in already that they get injected through. And so once they have induced the seizure, the patient will get injected with the FDG, and then you wait a minute or so, and then they treat them for the seizure or wait till they come out of it. So the goal there is to inject them while they're seizing, and then they can kind of calm down after that. After they are injected, then the focus should be on making sure the patient is safe, but also that they are in a quiet, dimly lit room and that they're not talking or anything like that. Just they should just be placed in a area where they can just recover from the seizure. And then uptake from the ictal and interictal phase are compared to look at any areas of focal hypo or hypermetabolism. During imaging, it is essential to monitor these patients for seizures. It's very important to carefully document any seizures that they had during the scan, before or after the scan. It is important to also stay with the patient, kind of keep eyes on them the whole time, because the tables are very thin. If you're doing PET like this, then their head is inside the machine and they're on a thin table too. So you don't want the patient to hurt themselves. You don't want them to jerk up. I mean, they can't help it, but sometimes they sit up. If they sit up, they're going to hit their head on the scanner. That can really hurt them. And so it is important to make sure that you are watching them at all times. And so this is the same picture again, because I just wanted to revisit that and show you that in this specific patient, notice the interictal, the baseline, it's hypometabolized, and then in the ictal phase, it's hyper. So image A is really just a classic representation of the interictal. And then this is pretty typical of what an ictal scan would look like and how that's used then for surgical planning, because the doctors can see what area of the brain is causing the seizure. It won't always be that specific area of the brain. It could be kind of anywhere. A lot of times you'll see it in the temporal lobes like that. Like I said, it's much better when it's temporal lobe epilepsy. When it's like parietal, frontal lobe, things like that, PET is not near as sensitive or specific, and it gets a little bit harder to localize where it's coming from. So this one is another one, and this shows you it's a little bit higher, more to the side, closer to your parietal lobes. But you see it kind of spans that area there. This case I wanted to show you because it demonstrates the close correlation with MRI and how beneficial they can be. This particular one is using something called a subtraction method, and sometimes techs do it. A lot of times physicians can do it on their software if they feel like they need it to kind of help them read the test. But it's just combining the ictal and interictal phases. It kind of overlaps them on top of each other, and then it will subtract everything out so that what's left is only the areas that are hyper-metabolized. And then that information is overlaid onto the MRI so that you can see exact areas of the brain that are hypermetabolizing. And MRI gives just such amazing detail in the brain. You see the differences in white and gray matter. You see all the sulca and the gyre, and you can kind of differentiate some of the different anatomy. Can't really do that with anything else. MRI is just really good for looking at that structure. And so for pre-surgical planning to be able to overlap the ictal scan data from the PET with the anatomical information from the MRI is extremely beneficial for surgeons because they can see exactly which little fold of the brain they need to go in and operate on. So fantastic for that. Because infection and inflammation will also hypermetabolize glucose, FDG studies can be used for infection and inflammation imaging in the brain. And so one example is encephalitis. This is actually in the SNMMI procedure guidelines that it's kind of a go-to for looking at inflammation in the brain. And this can be caused by infection. Usually that would be viral infections or autoimmune responses. And there is a specific autoimmune encephalitis, but there's also the autoimmune encephalitis that's secondary to lupus. And so there are other things that can cause it that are autoimmune mediated, but typically it breaks down to either infection or autoimmune. So the viral causes would be rabies, herpes, and this is all of the herpeses, herpes simplex 1 and 2, as well as Epstein-Barr, mononucleosis, and even varicella zoster, which is more commonly known as chickenpox or shingles. Also mosquito-borne viruses, tick-borne viruses, and then enteroviruses such as polio can all cause inflammation in the brain. The symptoms that occur would be like typical flu-like symptoms, especially at the beginning, followed by stiff neck, seizures, confusion, numbness in the face, muscle weakness, loss of consciousness, and even coma. That can be pretty severe because of the pressure that inflammation is causing on the brain. Any kind of inflammation on the brain can cause very significant cognitive impairment, behavioral issues, things like that, because it just adds a lot of pressure to the brain. Typical pattern of global hypoperfusion is seen in the brain. You don't really see as much of the gray matter, but you do see the striatal and limbic systems, and they will be hyperperfused. Some cases, this can cause localized hypermetabolism, and you'll see that with early autoimmune, the early autoimmune response. And that's just because the body is fighting itself. You have all these antibodies and stuff there, and so it's just kind of attacking your brain, and it causes kind of a global inflammation. But then over time, that tissue starts to die because of your immune system has kind of taken care of it. And so after that, it starts to become hypoperfused. Same thing with like Hashimoto's and the thyroid gland, because Hashimoto's is autoimmune. You have what will appear as hyperfunctioning at the beginning stages because there's more uh, inflammatory cells and things like that rushing to the area. So you have all this inflammation there. But then over time, as your body kills those cells and the inflammation, chronic inflammation turns to like atrophy or necrosis, those cells start to die off. Your body doesn't have any of those cells to attack anymore. And then it goes into more of a hypo metabolism thing where there's just a lot less uptake. So it's very similar to that. Now I mentioned the limbic system. I just want to remind you guys that the limbic system is a really complex system of nerves and nerve networks. It includes the hypothalamus, the thalamus, the amygdala, and the hippocampus. So this is encephalitis. This is an example of autoimmune encephalitis that's in its advanced stages. So this is where you see hypoperfusion of the gray matter, and you see uptake increased in the striatal. This over here, what you see that's red, that's the putamen and caudate of the striatum. That's something, that's where all your dopamine receptors and things like that are. But what you don't see is the typical gray matter around the brain. I inserted this small little picture here to the right of what a normal FDG scan looks like, so you could compare the two. And so you really see the effects of the inflammation on the glucose metabolism in the brain. Now, this is another example of autoimmune encephalitis. This shows bilateral increase in the putamen and the caudate, which is where the white arrows here are pointing to. Those look like little commas or apostrophes or whatever you want to call them in the brain. And so this has symmetrical hyperperfusion of that. In image B, you also see some hyperperfusion in the midbrain. That's where that red arrow is pointing to, down here right in the middle. And then bilateral mesial regions of the temporal lobes and image C here, but then you especially see them when you look at the coronal images in D, as these red little circles there. Otherwise, there's global hypometabolism, decreased glucose uptake. And so this patient ended up receiving prednisone therapy for their encephalitis. And I don't have a follow-up scan, but the case study report did say that after prednisone, their uptake scan looked normal. This is something I found interesting that's kind of a new emerging thing, is looking at the effects of the brain from long COVID. And this is a patient that had brain fog and kind of confusion and some cognitive impairment for 2 years following a COVID infection. And so they wanted to assess the brain and see if there was any evidence of long COVID or how that long COVID may be affecting the brain. And what they found was some frontotemporal hypometabolism that was persistent even after treatment. This kind of floats into the CNS system, but I wanted to mention it because toxoplasmosis is a brain infection and CNS lymphoma is cancer, but they can look very, very similar on our studies, or they can present similarly. But PET scans are used to differentiate them. Cerebral toxoplasmosis is a brain infection that's caused by a parasite. It's common in people with HIV and AIDS because they have, decreased ability to fight those things. So they're more susceptible to parasites and stuff that people who are not HIV or AIDS positive would be susceptible to. Cerebral toxoplasmosis can be effectively treated with medication, whereas primary CNS lymphomas are treated with radiation therapy and steroids. Neither CT nor MRI can distinguish between CNS infections and lymphoma, but FDG scans can. And so we are the primary imaging modality for that. So this is an example of cerebral toxoplasmosis. It is a parasite, so you don't really see a whole lot. You might see a little bit of increased activity in the gray matter, and you see that right where the arrows are pointing to, very mild. But lymphoma is going to be a very large space occupying lesion, and that will hypermetabolize. One thing that is important to note here is when we're trying to distinguish between infection and oncology with FDG, this is where looking at the SUV values is very helpful. If it is has a lower SUV value and it doesn't have a lot of like excess hypermetabolism, just maybe a little bit, then it's more likely to be an infection or inflammatory process. But if it is oncologic, if it's cancer, then it's more likely to be like super hyper metabolized and take up a ton of sugar and show up really, really bright on our scans. And this case that I have pulled up here is a good example of that, because in the cerebral toxoplasmosis, you don't really see anything. It's a parasitic infection, so all you're going to see is a little bit of really localized inflammation that might be there. But the primary lymphoma, you see a tumor and it's showing up very, very brightly. So that's how you would look at the difference. The SUV values for that lymphoma, where this arrow is pointing to, would be really high. Now, dementia and movement disorders, we will talk about at a later date when we talk about the other radionuclides. But FDG is used in dementia and movement disorders. This is an example of an FDG of a 56-year-old woman that's presenting with early onset dementia without family history of Alzheimer's disease. And images show bilateral posterior parietal, posterior cingulum, and temporal hypometabolism. And this pattern is suggestive of Alzheimer's disease with frontal lobe involvement. Now, this is in one of the earlier stages. As this Alzheimer's would progress, you would see the brain atrophy and you would see less and less and less of the red, less and less of the gray matter. For decades, FDG was the only FDA-approved radiopharmaceutical for dementia and movement disorders. It is still recommended for assessing atrophy and areas of hypometabolism and looking at the progression of the disease or just correlating with other imaging. But we have several other radiopharmaceuticals now that are used for imaging neurodegenerative diseases, dementia disorders, and movement disorders. And so a lot of times FDG's role now is just to correlate with those other imaging, the other PET imaging, and it plays a more supportive role. Now, we do have oncology, even though we're talking about it at a later date, just to make a note that FDG is used for oncology, and it is very difficult to see tumors sometimes in the brain with FDG because it takes up so much sugar anyway. But this is a person with brain mets. Brain metastases will have focused, increased, intense FDG uptake. And this person has one there that you can see the arrows are pointing to. This was a person who had melanoma, and it was on their toe and got treated, but melanoma is a nasty cancer. In this case, it metastasized and it went to the brain. So it is useful for that, but it is difficult because of the brain is already hot. So think about that for a second. That's the problem with brain metastases with FDG, is that the brain is already hot and the mets take up extra glucose. So it will show up extra hot, but it's hard sometimes to get that differentiation. It's also difficult to see if it's Mets or some other localized infection or inflammation because it really won't tell the difference. Now, FDG is not good for primary brain tumors. We will talk about that more when we get to FDG with oncology. But it's just not good for primary brain tumors. Even though it's still used for it sometimes, it's used more to look at inflammation versus radiation necrosis after the patient has had part of their brain removed. And that's done because it can tell if the tissue's dead or if it's inflamed, because if it's dead, it's not going to take up FDG at all. And if it's inflamed, it will. It on MRI and CT, it's really hard to tell if something has necrosis or it has inflammation, but FDG is able to show it very clearly. And like I said, we'll discuss that later. So moving on from oncology, I want to talk to you guys a little bit about the use of FDG with mental health and neurodevelopment disorders. This is something that has been around for research purposes for a long time. It's not necessarily on label. So most of it is like self-pay, maybe insurances might cover some cases, but mostly it's not. And so it's mostly used in research settings. There are some clinics, a lot of them in California actually, that will do mental health and neurodevelopment, mood disorders, things like that, look at the effects of addiction. And so it can be used for those things because anything that impacts glucose metabolism will show up. And a lot of those things actually have impacted glucose metabolism. So some of the things that FDG can assess are schizophrenia, bipolar disorder, attention deficit disorder, attention deficit hyperactive disorder, autism, depression, and even the effects of addiction, alcoholism, things like that. So remember, schizophrenia is a severe and disabling mental disorder in which people have been known to hear voices, sometimes they see things, and this is due to a chemical imbalance of the neurotransmitters. It occurs during fetal development, but presents itself usually during puberty. And this disorder can be treated, but it can never be cured. And there are two types of scans that can be done for schizophrenia. Structural imaging, which is usually done with MRI, that is just a snapshot of the brain. It looks at the blood vessels and it rules out other sources of the symptoms like infection, tumor, or damage. Remember, I told you guys that if there's any kind of infection or inflammation or increased pressure or space occupying lesions, anything that's taking up space or causing additional pressure in the brain is going to have behavioral symptoms. So, though, but it's going to depend on the area of the brain that is affected. Frontal lobe, they might have personality changes, problems regulating their emotions. They'll go to laugh, it will come out as a cry, or they may have a personality change and problems with like impulsive behavior. Whereas if it's in the temporal lobes, then they may have other things like phantom smells or hearing voices or things like that. So it really is dependent on the area of brain that is affected. So structural imaging like MRI and CT, they're really just there to rule out any other cause, like a tumor or anything like that. But functional imaging is actually showing us the biochemistry. It's actually showing us the glucose metabolism of the brain cells. And it is delivered via blood flow. So we're also getting a measure of blood flow to that area. And so it makes it beneficial for FDG to image things like schizophrenia that are known to have chemical imbalances, because there will ultimately be imbalances or inconsistencies with glucose metabolism as well. So if we're doing schizophrenia, it's typical to give about 5 to 10 millicuries. Now, the procedure guidelines say 10 to 20, and so you could give more. And then a lot of times these are done in research settings, which have very sensitive top of the line scanners as well. So same thing though, you'll image them about 30 minutes to 1 hour after injection. Patient is scanned supine with their head secured in a headrest. A positive test will show significant uptake in the basal ganglia and decreased uptake in the gray matter. And a negative test will show increased uptake in the gray matter. Not increased over normal, just that there will be more uptake in the gray matter, like a normal FDG study. And this is what it looks like for schizophrenia, comparing a healthy person to somebody with affective psychosis and somebody with non-affective psychosis. Notice that non-affective psychosis has just hypermetabolism of glucose globally throughout the brain. FTG can also be used to look at bipolar disorder. This is also has altered glucose metabolism in the brain. But because people with bipolar disorder will often have episodes of depression and manic episodes, it depends on where they're at with their bipolarism to be able to see how the FDG is taken up. So if they're in the depressive state, they will have low metabolism and they will have low FDG uptake throughout the entire brain. Whereas if they are in a manic episode, it will actually be hyperperfused in certain areas. And you can see that they're in the middle image that's labeled as mania. So that's a comparison of what bipolar disorder looks like. And it does have this kind of inconsistent pattern here where you have decreased uptake in certain areas. That is pretty normal for the mania part of bipolar disorder, and it won't always be perfectly symmetrical either, which is another way that you can tell that it's not normal uptake, is because it won't be symmetric in both hemispheres of the brain. So you'll notice that it's not completely symmetrical in any area of the brain. And now moving on to depression. This is depression imaging or PET imaging that's fused with MRI. And you'll notice with depression that there is just global hypoperfusion, just like the depression I showed you on the last one with the patient that had bipolar disorder. You just see this global hypometabolism of FDG. And now I want to tell you about a couple interesting cases. This one is extremely sad. I mean, they all are, but this one was extremely sad. And so I left out some of the details of the patient's name and stuff. But there was a case out of Texas where a woman named Tina was accused of murdering her 10-year-old daughter. Horrific crime. Dina was claiming that she heard voices in her head that drove her to it and kind of drove her crazy. And during her first trial, she was diagnosed by psychologists as having schizoaffective disorder. But her first trial resulted in a hung jury. During the retrial, her defense attorney, because she was up for the death penalty in that case, for murdering her own child, and it was really brutal, vicious murder. But during the retrial, the defense attorney had brain imaging taken, had functional MRI and FDG PET scans. And so he introduced that new evidence that actually showed her PET scan revealed that she had an inoperable mid-brain tumor. It was a large tumor deep in the middle of her brain, and there was no way they were ever going to be able to operate on it, and it was probably going to prove fatal. And so she was later found not guilty due to insanity. I want to point out there that in cases like that, a lot of times patients doesn't mean that they're scot-free and that they go walk the streets. It most of the time means that they become committed to a mental institution or something. Now, because this one's was an actual brain tumor, she probably got other medical care afterwards. You know, like I said, probably comfort care because it was an inoperable tumor. Very, very sad story for this one. But I wanted to demonstrate to you that this is something that's actually happening a lot more these days, is that people are using PET scans and even sometimes SPECT studies to look at psychological or mental health disorders that may have been the cause of abnormal behavior that led to them committing a crime. So it used to be that defense would get an attorney that said the person was unfit or suffering from mental disorder, and then the prosecution would get their own attorney and that, or their own psychologist, and that psychologist would say the person was fit and knew what they were doing. And so it would just come down to which psychologist the jury believed more. And now more and more prosecutors and defense attorneys are using imaging to support a psychological diagnosis. And in most of the cases, the defense attorney is just trying to get them off of the death penalty and into even life without prison, but they're trying to kind of lessen their sentence or just get the death penalty off the table. And so it's becoming kind of common. Here's another case, surprise, out of Florida. This is the state of Florida versus Calvin Lee Coleman Jr. And this is one where the defense was just trying to get the death penalty off the table. This happened over a decade ago, but just one day, an argument between Penny Coleman and a hotel. She was a hotel resident. The family was living in a hotel in Ocala, Florida. But an argument between Penny Coleman, who was the mom and the wife in this case, she got in an argument with a hotel worker, a hotel employee, about their children riding their bikes. And so Mrs. Coleman got upset by the altercation. She called her husband. He later came and confronted the front office staff. He was very aggressive and confrontational, so the police were called. They came to the scene. They did not think anything was wrong. They thought it was just a dispute that had now been settled and everything was calmed down. Mr. Coleman went back to his room that they were living in, and the police left. 5 hours later, Mr. Coleman shot and murdered 2 hotel employees. Mr. Coleman claimed that he was innocent, and he was facing the death penalty. The prosecutors were pursuing it due to the just because of the circumstances. The people that he shot were not involved in the altercation at all. They were 2 random hotel workers that had not been involved to that point. One of them was a maintenance worker, and I can't remember what the other one was, but Neither one of them were Rebecca Crew, the original motel employee. None of the people he confronted. And then this was 5 hours later that he actually committed the murders. And so the defense claimed that Mr. Coleman had cognitive impairment and were trying to get the death penalty off the case. So the defense actually got imaging on him. He underwent MRI and PET. And here are his PET images. And so in this one, they actually did a lot of quantitative analysis on his. And so in this one, they have increased metabolic rate in the cerebellum, and that is indicated by the kind of gray and black areas down here. This is where the, so you can't see my pointer, down here in the gray and black areas in the cerebellum. And that's basically the quantitative analysis software has kind of highlighted those areas of being abnormally hypermetabolizing. And then it pulls that data and does statistical comparisons to look at the metabolic activity of Mr. Coleman compared to other patients that were his like same sex and age and things like that. The patient's cortex shows a normal rate of metabolic activity, but the patient has a decreased neocortical cerebellar activity ratio, and that's indicated by quantitative analysis. So what they're saying there is that this area is kind of abnormal. And then this is the chart that looks at a different area of the brain. This is the thalamus to cerebral ratio, and it looked at the region of interest analysis for the regions that are circled. So this one is circled in the red down here, and then the cerebellum is circled also. The thalamus analysis is on the right, and then the cerebellum is pictured on the right and the thalamus is pictured on the left. But the defendant's right thalamus would appear to be within range for normal metabolic activity compared to age and gender match controls. And that displayed the absence of gray regions, so there's nothing showing up there. But the defendant's cerebellum appears to be functioning higher than normal compared to others his age and sex. But when looking at the ratio, there's also significant decreased ratio in the thalamus compared to his age. And so they were looking at all of that, and you can see the standard deviations and things like that that they were looking at for each area. And then this is something different that's looking at the areas in red here that are defined. They're looking at the anterior cingulate and the posterior cingulate. And notice that the data is not printed there, but they are about 12 standard deviations away from the age-adjusted mean. And so then the metabolic uptake in the pons is about 10 standard deviations below the mean. So both areas had statistically significant decreases, and this specific finding is consistent with traumatic brain injury. So as a result, the neuroimaging, once it was all assessed and quantitatively analyzed, Mr. Coleman was diagnosed with having fetal alcohol syndrome, chronic traumatic encephalopathy, and traumatic brain injury. This is something that correlated with history and other findings. So a detailed look at his life events and his history supported those. His mother was a longtime alcoholic, and she had heavily consumed alcohol the entire time she was pregnant with him. He also had a brain injury at the age of 11 that was marked by loss of consciousness, followed by a drop in language and reading scores in school. And that was the result, I believe, of abuse in the home, not with a mom, I think, but with another family member. But he had such severe child abuse that he actually had brain injury that caused loss of consciousness, and he had a very steep drop in his language and reading scores in school after that never really recovered. And then at the age of 24, he was struck multiple times in the head by a hammer. And so he had some brain injury from that as well. And then he also had a family history of mental disorders on both his mom and dad's side of the family, extensive um, diagnosis, multiple generations, multiple people, close and more distant relatives, both sides of the family that had severe mental disorders. And he himself, through the process of being evaluated, was diagnosed with several different mental health issues. And so eventually he was sentenced to life in prison without parole. I do want to point out, though, when these people are sentenced to life in prison without parole, when they find that there is something on their imaging, they're not sent to a regular prison. They're often sent to like a mental health prison, where they're kind of like committed. It's still a prison, but it's a little bit different. And so they're kept not with the normal like prison populations like that. So it's a little different type of facility. But I wanted to share this case with you because it highlights the growing trend in violent crimes, especially murder and death penalty cases. Often the person is known to be guilty, and the prosecution is seeking the death penalty, whereas the defense is just trying to get the death penalty off the table. When imaging reveals that there's a cognitive impairment or disorder that likely impacted their behavior at the time of the incident, then that person does not typically get off free and become a free person. It typically means that there's still a danger to society, even if they can't necessarily always control it or there's a medical condition underlying it. And so instead of the death penalty, it usually means they go to like a psychiatric prison. And there are a lot of moral and ethical considerations in cases like these, because they're typically like murder cases and you still want justice for the victim's family. They become very complex. And so, the use of medical imaging for psychiatric reasons also raises some moral and ethical questions, especially with FDG when there are so many other things that will affect glucose metabolism in the brain. It becomes very important to rule out all other causes of any abnormal uptake in part of that analysis because it can make a big difference in the outcome for that defendant. Just because, it's not necessarily reliable, or FDA, I mean, for the most part, it's considered reliable. It's been in use for a long time, but it's not something that we do on a regular basis or is something that is part of our like procedural guidelines from the SNMMI. So it's just something that a lot of times the attorneys or the state ends up paying for as part of these cases, which leads to even more ethical and moral discussion. So there is a lot to unravel with these cases, but I just wanted to let you guys know that it is an area that's emerging in our field. It's a non-oncologic use of FDG. And that's it for this lecture. Thank you for listening. Hope you enjoyed it. Hope you learned a lot. And thank you.